Hi everyone, I'm Dr. Nadia Gomez. I'm the Vice Chair of the Gynecologic Surgery and Obstetrics Department at Kirk School of Medicine at UNLV, and I'm here with my colleagues today.
I'm Dr. Jennifer Baynosa. I work for the Department of Surgery, and I am a breast surgical oncologist taking care of breast cancer patients.
I am Dr. Lorena Suarez-Kelly. I'm a surgical oncologist at the Department of Surgery, and I take care of all general surgical oncology cancers.
And today we're going to be talking about the most common cancers that we see in women, including breast cancer, uterine cancer, colon cancer, and we'll touch a little bit on ovarian and cervical cancer. So, Dr. Suarez-Kelly, what is cancer?
So cancer, very simplistically, is when your normal body cell has an abnormal mutation and it loses the ability to regulate its growth. So then that cell becomes unregulated, it starts growing rapidly and dividing uncontrolled. And these can happen anywhere. It can happen from any cell in our body. So there's over 100 different types of cancer, just depending on where the cell originates. And then once the cells start dividing uncontrollably, then they can decide to grow up into actual tumors and then eventually can spread to other parts of the body.
Right, and they can invade other organs. Mm-hmm.
And, it's important to note the difference between like a malignant tumor versus a benign tumor. And so benign tumors are tumors that grow and can get big but don't have the ability to spread. Whereas malignant tumors have the ability to spread and go elsewhere.
So how do we screen for this, Dr. Baynosa?
So each different type of cancer has different screening, what we call modalities or things that we can do to help find cancers early. So the importance of screening, one is knowing which cancers we can screen for. So in women, we typically screen for colon with colonoscopy. We screen for cervical and uterine via
your pap smears.
Pap smears and even some endoscopic ultrasounds of the uterus if you have abnormal bleeding that you take to your doctor. And then for breast, we usually recommend mammograms on a yearly basis. So the importance of screening also is because we really want to find cancer in the early phase when it's easier to treat before it spreads, because then it is more difficult.
Right.
And I think it's important to note that because your doctor sends you for screening, that doesn't mean that they think you have cancer or that you have cancer. It's to make sure that you don't have it, and if you do, to catch it early.
Correct. And we've seen that a lot in breast cancer, in particular the mammogram screening. We saw how it truly has increased detection rates for breast cancer. And October is our Breast Cancer Awareness Month. And in particular, we want to talk about breast cancer. I know the incidence is 1 in 8 women, so that's why it's very important to start screening early. Do you want to talk more about breast cancer?
Sure. So the good news is that breast cancer is highly treatable. We do like to find it early, and there are lots of different treatment options for breast cancer. So, cancer care has become very complicated in the medical community, and a lot of tumors that we have been able to find and understand, we now have different treatment options for different parts of the cancer cell, which makes what we call personalized treatment for cancer. And so breast has very good survival rates. And we have very clear guidelines of how we treat breast cancer. And so it's pretty, I don't want to say cookie cutter, but a lot of women think that, the care in the community that we're in, they need to go to like big cancer centers. They have to go out of the community. They need to go to cancer centers in LA or Arizona that they hear about. But we have a very good cancer care here in the community, and we have really good treatment options, and it is all the same regardless of what cancer center they go to.
Right. And I know some cancers, there are some genetic predispositions to cancer, and some of the cancers that we're talking about can be found in the same individual. For example, Lynch syndrome is one of them, which touches on colon cancer, as well as some uterine cancer. And so we ourselves have seen some of the same patients throughout UNLV Health. We're a multidisciplinary practice. And so we, treat patients together in a multidisciplinary fashion.
Yeah. And, speaking of, genetic mutations, and it is important to tell your doctor all your family history of cancers and really, digging in and finding out what your family history is. Because a lot of times people don't talk about their health conditions unless we ask. And once we know certain, risk factors, we can then talk about cancer risk screening, including genetic testing. And if we find that there is a genetic mutation that is more high risk of a certain type of cancer, we have different guidelines for screening for those patients, kind of earlier screening and more targeted screening, so we catch the cancers early.
Good. And tell me about colonoscopy. When should we start getting screened for colon cancer?
Yeah, so colon cancer, we don't really talk about it as much with women's health, but it's a disease that we should talk about more often. It's actually the third most common cause of cancer in women, and it's the fourth most common cause of cancer-related deaths in women. So it's pretty prevalent. Cancer screening recently changed the guidelines from 50 to 45, so you should undergo your initial screening colonoscopy at 45. There are other screening modalities such as stool, DNA samples, less, that's a little bit, not the most reliable is the colonoscopy because you can visualize and see and also treat the polyp or remove the polyp. There's other modalities such as like stool DNA samples or stool blood samples or some CT scans for screening, but the tried and true process has really been colonoscopy. And cancer screening for colon cancer has actually been pretty unique, as it not only helps identify cancers earlier, but it actually has helped decrease the occurrence and the prevalence of colon cancer, because colon cancer results from when we develop polyps or abnormal growth in the lining of the inside of the colon. And those are kind of those abnormal cells that we talked about that become abnormal, start to divide, and then turn into more aggressive cancer. So if we remove the polyp early before it becomes a cancer, it actually decreases the occurrence of cancers. So colonoscopies not only help prevent cancer, but also catch them early and treat them early.
Right. And for our patients, colonoscopy. So colon is the intestines. Oscopy is putting a camera through it. I love the way you explain it that way, because it's the same way I explain to my patients who are having abnormal uterine bleeding or postmenopausal bleeding after menopause. You should not have any bleeding. And I explain to them the same way that you can get a colonoscopy, you can actually get a hysteroscopy. Hyster means uterus, oscopy means putting a camera in the uterus to evaluate it. And just like my colleague, Dr. Baynosa, said, that yes, we can evaluate the endometrial lining. Endometrial lining is the inside lining of that uterus. If you're having any problems with your menstrual cycles and you're concerned for uterine cancer or endometrial cancer. And endometrial cancer is actually the most common gynecologic cancer that we see, in particular type 1, which is mostly due to unopposed estrogen. And I always tell my patients that unopposed estrogen is anovulation. It's due to a couple of things. One of them is not being able to ovulate. In particular, we see it with a higher BMI, so body mass index. So patients that are obese have a higher risk of endometrial cancer. And I talk to my patients about that all the time. But there are some patients, that we see that can have breast cancer and get on medications that can also act on that uterine lining, such as tamoxifen therapy. In particular, postmenopausal patients, we've seen that. So we really counsel our patients that any abnormal bleeding throughout your age or your cycle, your reproductive years, please see your gynecologist to get evaluated.
Are there any symptoms besides bleeding or other symptoms that you tell patients to watch out for?
Yeah, that's a great question. I think in particular for endometrial cancer, is mostly you're going to see it in the clinical symptoms of irregular bleeding. Mm-hmm. And what I mean is not having a normal menstrual cycle. So even skipping menstrual cycles, not having a menstrual cycle can also do it. Also, when we start talking about other conditions, like cervical cancer, we always say that at age 21, regardless of being sexually active, we should start screening for cervical cancer with pap smears. And then ovarian cancer, unfortunately, there's no specific screening tool. We do find that disease later in life and advanced stage.
Mm-hmm. Can I ask about the Gardasil vaccine and what it's done to decreasing the prevalence of cervical cancer?
Of course, yeah. So Gardasil vaccine, thank you for asking me, Dr. Baynosa, is a vaccine that we use for human papillomavirus. And we actually started educating the pediatric population to be sure that we start at an early age. We actually started at age 9. And that has dramatically decreased your risk of cervical cancer. So much that, cervical cancer, we see most of it in underserved nations. And, we're very, very grateful. We try to push the HPV vaccine and make sure that, our young adults are getting and our kids are getting vaccinated.
I didn't know that. I thought it was 11. I was going to have my 11-year-old talk about it when his next visit, but I guess we got to do it now.
9 years old. And we actually have it in our office. So, you can come in.
Both of my kids have already received it.
And I think, going back to screening and kind of what the goals are for screening, because I think that's important. The goals is the screening test doesn't diagnose cancer. It tells you whether you are at risk of having it, and then additional tests are needed. So, like you said, ovarian cancers, there's no great screening modality, because I think to really meet like good screening criteria is that we have to be able to find the cancer early and have it be a cancer that we can treat early or help decrease the risk of it occurring. And then also have it be something that improves survival. So if we diagnose it earlier, will there be benefit in increased survival? So there's been studies and shown that is significantly positive for breast cancer, for colon cancer, for lung cancer, which is also the second most common cause of cancer in women. And then same thing with cervical screening.
Mm-hmm. Absolutely.
So I will start going over breast cancer screening, because we haven't really gone over the guidelines for breast cancer screening yet. With October 1st being Breast Cancer Awareness Month, this is going to be widely spread, usually in all doctors' offices, especially. And you'll see it on the news and on multiple programs on TV, pretty much. But the screening guidelines for breast have changed recently and can get a little bit confusing when not everybody sees eye to eye with screening. Mm-hmm. And so, the cancer societies kind of see things differently than the United States Preventative Task Force that put out this big article several years ago that's saying that we didn't need to screen as often. So I think women got really excited saying, oh, I don't need to go in for my mammogram as often, which I think has done a disservice to women and also a disservice to finding cancer early. So newer guidelines that I think everybody has agreed on, and the United States Preventative Task Force just kind of came down and said that they've more agreed with the cancer societies. And so they've actually changed the recommendations that they had given previously, stating that women should really be advocates for their own health. And so I think it's really important to understand your risk of developing breast cancer, understanding that, genetics only play a portion in about 10% of breast cancers. So a lot of women will come in and tell me that their mom had breast cancer, therefore they're going to get it. And I have to remind them that only 10% of breast cancers really are genetic. Most of them, unfortunately, are what we call sporadic, meaning that they just happen for no reason. 1 in 8 women will get it just because, unfortunately, we have breasts. Men can get it also, they just don't get it as often as women. The actual guidelines say that you should start having a conversation at the age of 40. So at the age of 40, you should have a conversation with your OB-GYN or your primary care doctor about your personal risk. And we have risk assessment tools. You can actually find it online. So if you go online and put in, breast cancer risk assessment tool, it'll come up and you can pop it open and you can put in your own data to find out what your lifetime risk of breast cancer is. And so between the ages of 40 and 44, it's recommended to start talking and potentially starting mammograms at that time if you have a higher lifetime risk of developing breast cancer than the average woman. And then starting from the age of 45 to 54, you should have yearly mammograms again. And then starting at the age of 55, you should go back to risk assessment and conversation to seeing if you can go every other year versus yearly, depending on your personal risk of cancer. So
Perfect.
I think that's important to know.
Absolutely. When do we stop colonoscopies? How do you counsel your patients?
Just to kind of summarize too, the screening timelines, we know we talked about, starting at 45 and then doing annual screenings then. One caveat is if you have a first-degree relative that has colon cancer or a first relative with high-risk polyps, you should actually start screening at 40 or 10 years before their age of diagnosis. So if your first degree family member is diagnosed at 39, then you need to start at 29. And so that's the one piece that often gets missed. And then after that, it should be every 10 years, unless there's abnormalities or you're high risk. That would sometimes would be 5, or depending on what they find. Now, after colonoscopy started, when do we stop? The guidelines currently say 75. And so recommend aging until 75. And so, would that be something that we need to do? But I think that's something that really comes down to really discussions with your doctors and your GI doctors about, overall cancer risk. And the main thing is long-term survival. If there's a really healthy 75-year-old who, we're thinking has got a good, 20, 30 years still left to live, then, I'm a little bit more cautious on those, just because we do see newly diagnosed colon cancer patients in the early 80s, late 80s, who are pretty healthy, independent, and functional, that we could have maybe caught earlier. So I think the guidelines are still 75, but, I would caveat that, having careful discussions and, discussion with your doctor before completely stopping is important.
And so then how do I counsel my patients, what are the signs to look for if they're concerned for a colon cancer or a breast cancer?
I think it's really important to know that, for screening, you have no symptoms. So that's when we go the routine screening and check to make sure that if we find something early. If you have symptoms, then we need to get you in for diagnostic testing. And so unfortunately, a lot of cancers, even colon, breast, and any other cancers, a lot of them tend to be tricky and have no symptoms. And that's kind of the number one symptom, is no symptoms. After that is, other symptoms, such as for colon cancers can be blood in the stool, noticing like red blood or, red colored stool. Also like dark or like black colored stool, or tardy stool. Changes in the bowel habits, going more frequently, not frequently. And also changes in bowel
Width?
Stool diameter and stool size. Oftentimes, patients with colon cancer will be like, all of a sudden my stool started becoming really thin. And that's usually because it's trying to pass through an area that's really tight and structured by a tumor. Now, some of those symptoms are, you see them kind of in more advanced cancers, or, when we have a large tumor to cause symptoms. Other, vague symptoms is like weight loss that's not explained, unintentional weight loss, or unexplained fatigue. You're just kind of chronically tired and don't have a really good reason why you're feeling so tired and run down.
And what about breast cancer?
So for breast cancer, like Dr. Suarez-Kelly said, unfortunately, breast cancer and early breast cancer doesn't have a lot of symptoms, which is why screening becomes such an important part of diagnosing breast cancer early. Because once breast cancer is to the point where it has symptoms, that typically means it's a larger tumor that you can actually feel in your breast, or skin retraction and dimpling of the skin. And so at that point, those typically are higher stage breast cancers. And those are really the major symptoms of breast cancer. There isn't a lot of breast cancer that presents with pain, because that's always a patient's worry, is like, I have breast pain, therefore I am worried that I have cancer. Only 3 to 4% of breast cancers actually present with pain, so it's not a typical symptom. So the major symptoms are palpable mass in the breast, where you can actually feel a tumor or a lump or bump, and skin changes. So those are the ones that should get you to your primary care or your OB-GYN pretty quickly, so that a mammogram and ultrasound can be ordered.
What about a lump in the underarm, the armpit?
So it's interesting. So we all have breast tissue in our armpit. So, we all have axillary breast tissue. And then that's also where the lymph nodes go, where the breast cancers typically will present with lymph node involvement underneath the arm. So any lumps underneath the arm are also worrisome for breast cancer and need to be evaluated.
Right. So would you recommend your patients to do self-breast exams every month?
So that gets confusing. So it gets confusing because, several years ago, everybody came out and said that doing your own self-breast exams doesn't increase the diagnosis of breast cancer. And so we stopped telling our patients to do breast exams monthly. And so we no longer teach our patients to do breast exams, because mammogram is so important for screening and usually finds those breast cancers before you would even feel it on a breast exam. However, I will tell you that you should know what your own breasts feel like. You should know what changes they're going through. And unfortunately, changes happen on a monthly basis with the hormone exposure. And so they tend to get, more dense, more tender. And so it's important to know kind of what your breasts do. Therefore, if you notice a change, notice skin dimpling, notice redness of the breast, notice a mass, you can bring it to your primary care.
Absolutely. I always tell my patients to go ahead and examine their breasts. I think it's a minimally invasive procedure.
I mean, every part of your
And,
body you
yes.
should be looking at and realizing when there's changes, because that can be a sign of a problem.
What about a patient who had a recent mammogram that was normal but still feels a mass?
I still think that's important because mammogram screening is typically very, very, what's the word?
Not specific.
But it's usually very good of seeing masses if there is going to be one, but we have other diagnostic tests. So mammogram occult cancers can happen, meaning that there is a cancer and that is present in the breast that is not found on mammogram. And we have other modalities that we can examine a breast with. So we can do ultrasound, or we can even do MRI, which is another screening modality for breast. It's not recommended as yearly screening without a genetic component, but it is available if there is a palpable mass that your primary or OB-GYN or breast surgeon feels that the mammogram is showing negative.
Thank you for joining us in our conversation. If you are in the Las Vegas community, please make an appointment to see us. We are here to serve you. Look up UNLV Health. Thank you.